Please welcome to the stage Axios senior reporter Caitlin Owens.
Good morning, everyone. Thank you for joining us today bright and early. Welcome to Behind the Bill, Understanding Health Insurance and Costs. Access to healthcare and industry affordability is top of mind for Americans right now. To dive into the intricacies, I have an architect of the Medicare Prescription Drug Benefit and Health Savings Accounts. Please welcome Joel White, President of the Council for Affordable Health Coverage. Thank you for joining us this morning.
Yeah.
Let's dive right in. You're the stage setter. How can we start to wrap our heads around the U.S.'s healthcare cost problem?
Well, thank you. It's an important conversation we're having right now. I think affordability is the number one concern in healthcare because Americans are getting crushed by rising healthcare costs. And I think the issue is pretty simple. We don't have functioning markets anymore. And that's the result of decades of policies and market consolidation that rewarded size and scale and higher costs. And so when you reward something, you get more of it. We have higher costs as a result of those policies. So the thing I'm optimistic about is that we can change those policies and drive the costs down. But getting our heads around it is difficult. I think the way I think about it is, what does it mean for an individual or a family? A typical family this year is going to spend 20% of their income just on premiums. In 6 years, they'll spend 40%.
Wow.
Because costs are rising much higher than wages. And we don't want to live in that world because that means families spend less on education, food, housing, etc. But right now, it's about $27,000 all in for a family premium. Put another $3,000 or so on top of that in out-of-pocket costs. Your $30,000 a year, I mean, that's the cost of a Chevy Trailblazer every year.
Well, I certainly don't want to be paying 40% of my income on health insurance.
No.
So there's always been big fights in Washington over who's to blame for these costs, right? Whether it's the insurers, the drug companies, hospitals. What say you? What's your opinion?
I think there's enough blame to go around. I think the incentives are misaligned, really is what the issue is. And if we don't have functioning markets, the incentives are misaligned. Everyone's got an incentive to get bigger and drive up costs, make more money in the system. And so I think what we see right now, just for perspective, is 97% of all hospital markets are uncompetitive. These are big systems that have come together. They exercise market power, they drive up prices, which then get passed on to premiums, which drives those premiums up higher. The number one cost driver of higher premiums is medical costs, and it's primarily hospitals and doctors. We see the same dynamics on the insurer side. Most markets are uncompetitive across the US, so there's little price competition in premium world or in service world, and I think that is something that we can address, and Congress is taking a few swings at it.
Are there any sectors that you think are working as they should be right now?
Yeah, I think the more that we see consumers empowered, the lower the costs are. So, for example, most people get their coverage through an employer. I mean, don't tell Congress this, but not everyone is on a government program. The employer market makes up more than half of where people get their coverage, and it works pretty well there. And I think the reason is twofold. One, we regulate the employers less, so there's less of an incentive to get big and reward higher costs. And two, we partially subsidize it through the tax code. And the subsidies for an employer policy are about $2,000 a year. In Obamacare and Medicaid, they're about $6,000 a year. So the extent we can keep people in employer coverage, we spend less from taxpayers. They also have better access to doctors and drugs, and more agency over their choices. So that's really important. It's working pretty well in employer world.
So I did not know what you were going to say to that question. I did want to actually talk about employer insurance next. As most people in this room, that's probably what we have, right? You say it's working pretty well. Do you think that there needs to be anything done to lower cost within the employer market, or should policymakers kind of leave it alone?
Oh, absolutely. So if you want to think about commercial insurance, it's individual market. That's primarily Obamacare. There's small businesses, and then there's the big businesses, right? Big business world, like I said, things are working pretty well. Costs are still high, and that's largely a result of health services and prescription drugs. So we can if we lower those service costs, those drug costs, that will translate into lower costs for employers. And we've seen the PBM reform bill, for example, the Department of Labor PBM rule that is trying to change incentives in those markets to make them more transparent, but also allow employers to shop for lower costs. But in the small group market, where the small businesses are, that market's been decimated. Right. Absolutely decimated. It is impossible as a small business owner to really afford coverage for your employees. And that was primarily the result of the Affordable Care Act. So right now, half of the Obamacare market is made up of small business employees, about 12 million people. When they lost their small business coverage, they lost better access to doctors and drugs. They got more management of their services. They got narrower networks and higher deductibles. So by creating those incentives for small businesses to drop, we got those people worse coverage at a higher cost. And that's what the system's designed to do, drive people into higher cost markets that reward this bigness, this largesse. So we need to fix those incentives. We've been advocating for a small business coverage credit, expanding that. Other reforms like association health plans, expanding HSAs. These are all designed to get small businesses back in the insurance game so they can compete, hire people, grow, do better.
You've brought up already today consolidated provider and insurer markets. Yeah. What should be done about those?
We need to break them up. These are localized monopolies. Like I said, 97%. You could drive from here to Sacramento, down to Miami, up to Rangeley, Maine, never go through a competitive hospital market. Same thing is happening in physician world. People are joining bigger groups or they're getting bought out by hospitals. In the insurance world, what we see is these very vertically integrated entities where the insurer owns the PBM, owns the pharmacy, sometimes owns the doctor or the clinic, and imaging center. And this consolidation is driving market power. Prices are going up 5 to 20% in those markets, higher than they otherwise would be. And there's games that get played. So I think the first thing we need to do is break them up. We got the Sherman Act and the Clayton Act, which are tools the Trump administration really hasn't aggressively used. They need to more aggressively use them. Clayton Act to break up the monopolies, Sherman Act to end anti-competitive behavior. The second thing we need to do is Congress needs to end some of the gaming that's going on and in the policies. And what we see in medical loss ratio is a fancy term, but we need to end the gaming there. Make those subject to false claims, maybe tax differentially transfers that are going within companies. And then on the policy side, we've rewarded nonprofit hospitals with lower input costs through 340B. So they get a discount on their drugs that for-profit systems don't get. They then charge everyone higher, buy low, sell high, and then they use that money to buy up physician practices. So more than 50% of doctors now work for a hospital. 10% of the physician workforce works for an insurance company.
When you say break them up, I think if you would have said that a year ago, 2 years ago, you would have been a lone voice in the wind, right? Yeah. Where it's been interesting as a reporter to see a little bit more of that chatter arise. Yeah. I guess what's your read on the political appetite for something like that?
I testified at the House Budget Committee back in January, and the Congresswoman from Vermont, who's very progressive, as you might expect from Vermont, basically said, I disagree with everything Mr. White said. He's an evil Republican. He wants people to die. But at the end of her 5 minutes, she said, I agree with Mr. White on one thing. We need to break up the monopolies. And we saw that with AOC at the Energy and Commerce hearing. We've seen the progressives kind of come out and say, this is bad for consumers. But we've also seen the Republicans say the same thing. Greg Murphy, John Joyce, Brett Guthrie, Jason Smith. There's a concern that we don't have functioning markets. We need to align the incentives to get lower costs.
So that is a big one to watch, in my opinion.
100%.
It's obviously an election year. Healthcare costs are a big deal.
Yep.
How would you rate what the Trump administration and this Congress have done to make healthcare more affordable?
Not enough.
Can you say more?
You want an A to F?
No. Just why do you say not? I mean, if you want to do A to F, be my guest.
I'll avoid that.
But you said not enough. So why?
The one major bill they've passed is the PBM reform bill. And I think that bill was a good bill. It addresses some of these misaligned incentives, like a PBM getting paid as a percentage of the drug cost will move to getting paid just a flat fee for their services, which is a good change. Didn't apply across markets, so it was narrower in scope. But that will drive down drug costs. And I think what the Trump administration did on Trump RX is really important because it empowers consumers, but it's only cash pay. So it's only the other 92% of us who have coverage somewhere, Medicare, employer, Medicaid, et cetera. It doesn't really help unless Congress or the administration applies those discounts to insurance deductibles, out-of-pocket costs. So there's a lot more that needs to be done. I hope they use reconciliation to drive down premiums and address some of these misaligned incentives.
So there is talk about reconciliation 2.0, lots of chatter. What are some of the healthcare items that you think could be included in that if it does happen?
Yeah, again, think about markets. There's Obamacare, there's small group, there's large group, there's Medicare, Medicaid. So I think in Obamacare, we had this shutdown, government shutdown, and then this protracted debate around extending these COVID-era bonus subsidies. Those would have reduced premiums by about 7%, mostly by shifting costs onto taxpayers. I think we can do better than that. If we fund cost-sharing reduction subsidies, that'll lower premiums by 11%. 17 red and blue states have high-risk pool programs, reinsurance programs. Those have lowered premiums by 5 to 40%. So we need to put those on fire and really generate lower costs in the individual market. Small business, expand choices, get more incentives on the table like the small business tax credit. In the large group market, I think we need to do the Aaron Bean bill on HSAs for all and really give employers flexibility to offer those HSAs to fill in gaps in insurance.
So something we haven't talked a ton about today are prescription drug prices.
Yeah.
We have talked about markets. You're clearly an advocate for free and competitive markets.
Yes.
Another trend we're seeing in the political world is that's less and less in vogue, right? The Trump administration is talking about MFN. Democrats have passed the IRA, Medicare negotiations. What is the future of prescription drug policymaking, and what's the role of free market policies?
Yeah, this is an area of frustration for me because people say we need price controls on drugs, and the U.S. doesn't suffer from too few price controls. We have too many. So we have an AMP cap, we have 340B, we have Inflation Reduction Act negotiation, we have inflation rebates in Part B and Part D, and you just go down the list. They all create these conflicting incentives and weird dynamics. So I think aligning the incentives to get lower costs, that's why Trump RX, I think, is really the way to go. If you get a 90% discount on a drug and the insurance price for that drug is more, well, I, as the consumer, have gone out and gotten that lower price. That should apply against my deductible.
Right.
That would, if you did that in Medicare, you would get immediate price relief to 70 million Americans. But the Trump administration bureaucrats are kind of standing in the way of that. But the second thing I think because most people have coverage, 92%, most of those benefits are managed by a PBM. And so people pay an insurance price. And what we see are these games that go on where the list price is not what the PBM earns because they get a rebate. And but the consumer is paying cost sharing against that higher list price. So the consumer's feeling it, the PBM's earning money, and everyone says, well, it's pharma's fault. Let's go get those guys. At the end of the day, like, you can get pharma all day, but if you've got coverage and the PBM's controlling the price, you got to change that dynamic. So I think MFN's a bad idea. I think Trump RX is a great idea.
Well, on that note, we are just about out of time. Thank you so much for sharing your insights with us today, and stay seated for some more conversations.
Thanks.
Please welcome to the stage Axios healthcare reporter Peter Sullivan.
Hey, good morning, everyone. I'm Peter Sullivan, a healthcare reporter at Axios and one of the co-authors of our Axios Vitals newsletter. We're really excited to keep the conversation going this morning with a leader in Congress on healthcare policy. So please join me in welcoming Congressman Adrian Smith of Nebraska. Hey, Congress.
Morning.
Well, thanks so much for joining us this morning. Great to have you. So let's just start off kind of broadly. I mean, we're talking about healthcare costs. What's kind of your top couple of priorities in terms of getting healthcare costs down, given that it is such a, as we talked about in the last conversation, affordability is a priority for so many Americans?
Well, there's a healthcare financing and there's actual healthcare itself that we've got a lot of work to do. We shouldn't just kind of shift around who pays how much. That's what the ACA, supposedly Affordable Care Act, that hasn't worked out to be so affordable. And just shifting that around, the American people want us. I think the American people want to be closer to their healthcare decisions, and certainly the financing too, so where they have more say, more choice of plans as well.
One of the big debates, we've seen the past couple months in Congress was around extending those ACA subsidies, enhanced ACA subsidies. Those have now expired. I mean, how do you feel coming out of that? I mean, is it a good thing that they expired? Does anything else need to be done in that sort of individual market space?
Well, when I get a text message from a clergy friend of mine in the individual market facing huge costs, some pending healthcare issues as well, it tells me we better get something done. So I'm very sensitive to that. I also know that simply throwing money at something, it makes the problem worse, and that's what we've been seeing over the last few years.
Yeah, I mean, on that point, I mean, you're on the Ways and Means Committee. They recently had a hearing bringing in some of the insurance CEOs. What were kind of your takeaways out of that hearing? Is there sort of legislation you think is going to come out of that, or what are the next steps there?
Well, I was glad that we had that hearing and had multiple companies come in, share their perspective, from their executive viewpoints. But when it really boils down, I appreciate hearing from CEOs, but I think really looking at what people are paying every month, what their coverage is or is not, that's what we need to focus on. And then ultimately, how do we have America become healthier? And with everything that's happened with the ACA over these few years, America's no healthier. And that's a problem because, as the prior speaker noted, Joel said, the cost of insurance is a reflection of the cost of healthcare, and we always need to keep that in mind.
Right. So let's get to some of those drivers. We talked about prescription drugs a little in the first conversation. Are there areas you think that need reform around prescription drug pricing? What's kind of your outlook there?
Well, when we talk about transparency, that's a very broad topic that can be channeled in different ways. But I see, some of the integration of, providers and insurance companies as it relates to the medical loss ratio. I mean, the exact opposite results have occurred from what was initially intended. I mean, speaking personally, took our daughter for a checkup, on back to school checkup, and just one shot, MMR, was billed at over $1,000.
Wow.
Now, did we have to pay that personally? No, but that contributes to what the premium is.
Yeah.
When that billing level, among other things, is set at that. And so I just think more transparency in terms of what is happening, other than that billing, is, I think, ultimately helpful to consumers.
On that prescription drug piece, President Trump has talked about his most favored nation policy to link the prices to other countries. What do you make of that idea? I mean, are you open to it? Do you think a more kind of market-based transparency would be better than that, or?
Well, of course, I'm a market guy, so I think that's important, especially when America is driving innovation around the world. I think we need to kind of expect other countries to participate more than they have, and we shouldn't have to foot the bill necessarily for the benefits of other countries. So, but I think we need to be very careful in terms of what that process looks like so that we don't discourage being the innovator in the world. Innovation has a lot of good things attached to it. I want to make sure we keep that innovation here.
Yeah. So let's shift to another kind of healthcare cost driver is hospitals, providers. Obviously, there could be work on transparency there too. What do you kind of see as the priorities around costs in that realm?
Yeah, I hear a lot about prior authorization, and quite honestly, I mean, my gut thinks, wow, that just seems very inefficient. Now, I'm encouraged that new technologies, AI and others, can help us sort a lot of this out. In fact, I think to really get America healthier, we need to unleash technology. And I will predict, as many folks can probably already see, there will be some opposition, I'm going to say fairly parochial opposition to utilizing more technology. But we have to unleash technology so that we can deliver more access to healthcare across America.
Yeah, I mean, on that space, I know you've done a lot of work on telehealth. What are kind of the next steps there? We've extended the Medicare flexibilities. Is there more work on expanding telehealth, or?
Well, yes, short answer on telehealth, yes. I'm a little partial to my bill as well on ECAPs, reimbursing pharmacists for testing and treating mild treatment of COVID, strep, and flu. Utilizing pharmacists who are deployed all across America, rural and urban, to, I think, utilize their expertise more. They're trained to do this, and a lot of other things too, and I think tapping in more to, say, pharmacists in this case, and some others, that we can have broader access, more affordable access for patients.
Yeah, I mean, to continue on that, I mean, you represent Nebraska, the rural areas. Those are some ideas I assume could help in rural areas. Are there other things in terms of rural healthcare that you're working on or should be done?
Well, I'm glad that the Working Families Tax Cuts bill last year included the $50 billion for rural healthcare. And it's, as you know, it's not prescribed very specifically. I think that's okay. I think that's getting folks having discussions that need to be had. Some of those conversations aren't exactly comfortable either, but that's okay. My district, I have 80 counties. I have more than 50 critical access hospitals, but no two of those critical access hospitals are alike. And I see how they wrap their services around the needs of the community. I think that's helpful, and then they obviously partner with other tertiary care hospitals that can provide the higher levels of care.
Are you hearing from providers maybe in your district or elsewhere, workforce shortages, whether it's nurses, whether it's doctors? Is that an issue that you hear about? Is there anything around sort of workforce that should be done there?
Absolutely. Workforce across the spectrum of skill for healthcare, I think, is a significant issue. I've got a meeting, I think, later today to discuss residency and graduate medical education. I'm going to say, and I don't claim to be an expert on all of this, but when 5% of medical graduates don't match on match day, I think we can do better, and I want to explore ways that we can really, especially amidst the shortage that we have, that we can find slots more efficiently than what we seem to be having right now.
Yeah, you also mentioned the tax cut bill from last year. Obviously, there were some other health Medicaid changes that fairly controversial. Are you still hearing from providers concerned about those Medicaid changes? You mentioned obviously the Rural Health Fund can help make up for some of that, but is that still a concern that you hear, and how do you respond to it?
Well, I think some of the controversy has died down. I think that we're finding out that it's not the end of the world when we have some work requirements associated and so forth. Now, when you really look at opportunities moving forward, when we have duplicate enrollment in Medicaid and receiving Obamacare subsidies, or duplicate Medicaid enrollment in multiple states, eliminating duplication doesn't take care away from anyone. And yet, we can find considerable cost savings. And I'm hoping that we can work together on starting there, realizing that people still have care, patients still have access there, but we can save a lot of taxpayer dollars.
That makes sense. So, that we're talking about last year's reconciliation bill. Now there's some chatter. There could be another reconciliation bill, that sort of fast-track process to get it through the Senate. If that happens, do you think there would be a healthcare element, perhaps as helping pay for it, to a new reconciliation bill?
Well, I think there could be. Obviously, we have a pretty narrow margin to work with. So it would have to be some pretty non-controversial items. I want to keep an open mind on what that might look like, realizing, though, that their time is short and the political margin is small.
Right.
So we need to operate in those parameters. But I want to keep an open mind about how we can move forward, sharpening the pencil on some fraud. And, we've seen things happening and more data on that all the time. So, again, I think there's room for improvement there.
Yeah, you mentioned the fraud. Is that something where you just have to have better enforcement to prevent fraud, or are there other ideas around fraud that have been going around?
Well, the information is still coming in, so I want to make sure that we're very deliberative on that front. But we have just things changing all the time, and when we talk about healthcare fraud, that can be a term that's not as descriptive as it should be in terms of, say, billing. Unintentional mistakes being labeled as fraud and maybe penalized as fraud. When there's just honest mistakes being made, we have to be careful there and not have punishments in place for something that was never intended. And now I do think that new technologies can help us sort a lot of this out, coding and so forth, and that we can end up in a much better place and assist providers in processing their paperwork in a more efficient manner so that we can reduce those honest mistakes.
Makes sense. Well, I think that's about all the time we have. Thank you so much for joining us.
Thank you. Great to be here.
Yeah.
Thanks.
Thanks so much.
Introducing our View from the Top moderator and Axios publisher, Nicholas Johnston.
Hey everyone, I'm the publisher of Axios, Nicholas Johnston. Thank you for joining us today on Peak Blossom Day. Hopefully you're on your way to the tidal basin after our breakfast this morning. If you weren't there already for sunrise, we're grateful for you all joining us this morning for this great conversation. Also hugely grateful to all of our partners at Axios. Nothing we do at Axios is possible without the support of our partners. The investments in journalism we make around the country, convening great conversations like today. And so very excited and grateful for Elevance Health and their partnership to make today's possible. And I'm very excited to welcome to the stage for a View from the Top conversation from Elevance, their Vice President of Public Policy and Issues Management, Elizabeth Hall. Elizabeth, welcome to the Axios stage. Good morning. Good morning. Let's start big picture. Why don't you introduce yourself a little bit to the folks here who don't already know you and tell us what you're focused on from a policy standpoint.
Sure. So as you said, I'm Liz Hall. I'm our Vice President for Public Policy and Issues Management. And what does that mean? It means that my team spends a lot of time helping our business leaders understand some of the problems that policymakers are trying to solve and how we can be part of the solution. And at the same time, we're working to make sure that policymakers understand how some of their proposals impact individuals in real life and in practice, and our customers in particular. And at Elevance Health, as you can tell, we're very singularly focused right now on affordability, and not just improving affordability and reducing year-over-year cost growth, but really looking at how we can bring down healthcare costs. And when it comes to policy and legislation, one of the places that we are really working on right now is to try to reform the No Surprises Act independent dispute resolution process, because what we are seeing in practice is that is actually driving health cost inflation significantly.
Let's go a lot deeper on that.
Sure.
So like, give us your viewpoint of what you saw as what like the bill's goals were and what it's achieving and where it's falling short.
That's a great question, and we really support the goals of the No Surprises Act. It is really important, and the goal is to take individuals and take patients out of the middle of disputes when an individual may not know that they're going to an out-of-network provider. Think about an emergency situation, going to an emergency room, not necessarily knowing someone is in network, or going in for surgery and not knowing that the anesthesiologist, for example, is out of network. And the law has done a great job of taking the patient out of the middle, and we really applaud and support that. Unfortunately, what we're seeing is that the disputes that are going through the process and that independent dispute resolution process are at a much higher volume, and in many cases are not for those surprise situations. In many cases, they are coming up for those schedulable services, which we don't think that the law was really intended to use it for.
We wrote at Axios over the weekend a little bit about that increased volume, about the incentives there. As you dig into that, what do you say is driving that explosion of dispute resolution cases?
Sure, and it was great reporting, and really applaud the work that has been done. As I mentioned, what we're seeing is an increasing number of schedulable services coming through the process. If you think about it, about 20 entities, just 20 entities are submitting 80% of the independent dispute resolution disputes and driving a lot of that cost. And they're doing it for things that individuals can predict, can know, can schedule, and may not understand that those claims are going through that independent dispute resolution process.
I mean, like how much of this is being then driven by less the patient provider than like third parties playing a role in that?
Great question. Like I said, 20 entities are submitting these, and it's a combination of individual provider organizations as well as these third parties who are consolidating and really helping providers try to use that process as a revenue generation process. If you think about it, we are very typically seeing, and I want to emphasize that, this is the norm and not the exception, that you see a claim come through or a dispute come through for a service that in network, the market rate, the negotiated rate might be, say, $3,000, and they are being regularly awarded in excess of $80,000 to $150,000 for that service. As you can imagine, those costs are borne by the individuals, the employers, the unions, and even the government that are providing that coverage. And so that is significantly increasing costs over time.
What's your view of some of the comments around as far as some of these payments are taking too long, they're being underpaid? How is the system working in that regard?
Yeah, no, it's a really great question. We believe that providers should receive market-based competitive rates. We want to make sure that they get appropriate payment. They are our partners in serving our members and making sure that they get access to good quality care. Unfortunately, many of the claims that are going through the independent dispute resolution process are actually ineligible for the process. You're seeing 40 to 60% of the disputes that go through the process regularly not eligible. And why aren't they eligible? They might be a Medicare claim, they might be a Medicaid claim, they might be a claim that's subject to a state independent dispute resolution process. They also may simply have not followed the rules. So first, providers should come to plans to seek negotiation, and in often cases they're going straight to the independent dispute resolution process. And as good stewards, we need to be, as health plans, good stewards of those dollars that those individuals are using to pay their premiums, employers are paying. We need to make sure that the payments are actually accurate and follow those rules. And so I can understand a provider may think something is delayed when we're actually going back and making sure that the independent dispute resolution entities and CMS and others are looking at whether these are actually
Well, let's come back to
eligible.
the dollars. If you were to take a step back and look
Yeah.
at like the affordability picture of
Sure.
that, how are these problems impacting the overall cost
Yeah.
structure?
So again, the law was expected to reduce healthcare costs overall. It was expected to be used in these rare circumstances, and it's being used very regularly. And so we're seeing it's expected that about $20 billion a year, up to $200 billion over 10 years will be, costs will increase because of the independent dispute resolution process. But I think what's really important to understand is we're early in this process. It is new, and you're seeing these exceptionally high rates, and providers who are in network are paying attention. And so not only are we paying the costs, we expect the costs to go up faster because providers are starting to say, I'm in network with you, I'm paying, I'm receiving in-network reimbursements. I could just exit the network and I could go get much higher rates through the independent dispute resolution process. And that's not helpful for the system, that's not helpful for consumers, and we really want to make sure we're getting appropriate
So
payment
seeing
for
these
services.
trends early is worrisome because they're only going to go one direction.
Significantly inflationary.
So let's be solution-oriented. We're in a room with a bunch of people who care a lot about healthcare policy enough to get up almost before dawn and talk about it. When they go back to their office and their agencies, what's your advice to them? What is their homework for them to be part of a solution to these problems?
I think we think that the law is very well intentioned and really just needs some simple reforms. And I would put them in two categories. First, operational and enforcement based. As I mentioned, a lot of ineligible disputes are going through the process. We are seeing awards given out for those. We need to actually make sure that the appropriate claims are going through the process and that they are actually following the process. And that's one set of reforms. The other set of reforms is really, as I mentioned, these awards where a procedure that would be paid $3,000 in network and is receiving an award so significant, 8, 9, 10 times the actual market-based cost. We actually need to tie these costs back to market-based costs. And these, like I said, these are not exceptional cases. These are not cases where someone has severe complications. There's nothing in the clinical record that ties back to those costs. And so we really do need to make sure that the process ties back to some type of market-based pricing.
As you give these marching orders to folks to head back to their offices, do you feel like you're being heard? Do you feel optimistic that there are going to be possible changes that need to be made to this?
Right. I think everyone is well-intentioned with this law, and like I said, it's done a really good job of protecting the member, and we do not want the member put back in the middle. We just think we need to make a few changes, and I think we've made some good progress. CMS has a regulation that's pending that would look at some of those operational issues, and I do think that a number of members of Congress are open to making some tweaks and some improvements.
The job's
to the
not done
process.
yet.
But it's not done yet.
Elizabeth, thank you so much for being here. Huge thanks to Elevance for making today possible, and we're going to bring Caitlin back up on stage for a big finish.
Thank you so much.
Please welcome back to the stage Axios senior reporter Caitlin Owens.
Our next speaker has decades of experience working on legislation aimed at expanding access to care, addressing cost barriers, and strengthening preventive services. Please join me in welcoming Senator Lisa Blunt Rochester. Senator, let's jump right in. Something that you have worked on recently that caught my attention was a letter from Democrats announcing an effort to look at private insurance reforms.
Yes.
Tell me about that.
Well, first of all, let me say how good it is to be here and having this conversation. Healthcare seems to be one of the #1 issues that I hear from constituents, and so do our members. And so Senator Wyden, and who is our ranking member on the Finance Committee, has compiled members from our Democratic caucus that range from Elizabeth Warren to Mark Warner to there's a lot of W's. I realize there are 6 of the 12 are W's.
Wow.
And Alyssa Slotkin, so from geography to generational to just ideology, to come together and say, we know that we have a broken healthcare system, and that while we had historic legislation with the ACA and expanded access, affordability is the key. If you can't afford it, it doesn't matter if you have it. And so this group will be, over the next weeks and months, doing deep dives on our healthcare system, particularly our insurance system, to make sure that we can really have an impact on the American people. And especially because as a country with the resources we have, we should not have the outcomes that we have. And so for me, you mentioned I come to this with decades of experience, but I think part of it was from being Deputy Secretary of Health and Social Services in Delaware back when I was in my 30s. And because I was so stressed out about health disparities, I ended up with high blood pressure. As the CEO of the Urban League, this was a #1 issue for us. As an employer, I was Secretary of Labor and head of state personnel in Delaware, and I saw it from the employer side. So right now, it's not working for employers, it's not working for government, and it's not working for families in our country. So we are laser focused on making sure that we have a bold vision for healthcare as we go into the fall.
And I know that initiative is just getting underway. But can you talk about some of the ideas that you have about what to do about employer health insurance costs?
Yeah. Well, I guess even to take a step back and kind of narrow it into that initiative, it's kind of like a twofold step. One is that with the most recent passage of the One Big Beautiful Bill, we saw a $1 trillion cut in what is going to support families with their health care, whether it's Medicaid or whether it's the tax credits. I had a Delawarean reach out and say his tax credits went from, or his premium went from $900 to $2,300 a month. He said, I'm not going to do health care. That was what he wrote into us. And so first, we've got to reverse those cuts. And then secondly, we have to reimagine how we pay for health care. So from the employer perspective, it may be that we are looking at new and innovative ways of paying for health care. The second is how we deliver health care. And that's everything from dealing with our workforce shortages, which I have legislation on. I have a nursing workforce shortage bill, which is bipartisan and bicameral, to whether or not people can do telehealth, and we really do dig deep into that kind of thing. And then the experience for our constituents. People are feeling denials, delays. It is a frustration that has bubbled up, and now for us, that is one of the things we're going to look at too, is how do people experience healthcare? How many ways do they have to go and cut red tape and jump through hoops and hurdles? That's going to be another big area that we focus on.
So some of your colleagues, and Joel and I talked about this in the first conversation, but some of them have talked about breaking up vertically integrated health companies that do more than insurance.
Yes.
What are your thoughts on that?
It's funny because even words like vertical integration, I don't think the average American was talking about that until recently. And I don't know if anybody else, I saw an exchange with AOC talking about vertical integration, and I think that made people think differently about it. I recently had a situation where I had to go to a doctor and they referred me to a specialist, which was across the hall. And I was like, wait a minute, how are you connected? And do I need a second opinion? And so now I think there's a new awareness that some of these business models might have perverse incentives. And so for us, again, part of what this movement is going to be for this working group is that we will be talking to experts, we will be talking to providers, we will be talking to insurers, but we will also be talking to our constituents about what is working and what's not working. As far as I'm concerned, if it comes to just creating incentives that is making money for somebody else but hasn't changed my health outcome, then that's a problem. That's why I said we want to look at new ways of even paying. The states many times are laboratories for innovation. And so even looking at, are we basing pay on value and outcomes and quality versus just, you did this service, you get this much money. And then there's the issue of transparency. And I think when we talk about even vertical integration, one of the things that I think many Americans are looking for is to understand, well, why am I paying so much? And when you have opaque, billing, and when you have opaque, people don't understand why it costs that much. This is an area where I also see a lot of bipartisan support.
Right.
And I think that's important too. People want to know that we're working on this together, that it's not just, this group over here is doing it. And that's why I think the process that we're employing is really important. It's not just about the product, but it's also about the process. And one thing I really wanted to impress upon people, especially as we're here with a health insurer, is that years ago I was involved in a massive project in state government where we had to shift our whole ERP, and there was a lot of infighting, a lot of, and I assumed the job, and what we learned was that it wasn't the technology that was the problem. It was change management that was needed. And so as we go into this process, people are going to have to be open-minded. People who are used to providing their services the same way or using the same types of reimbursement models, people are going to have to be open to change. And to me, that's going to be a big part of this as well, is how do we change people's mindsets and be open? A lot of times in this country, we hear a term, whether it's climate change, and say, well, that's that group's issue, or we're going to have to be open and recognize what is our goal, what are our eyes on the prize about? And it truly is about making our country healthy. It is about lowering costs, access. There are still millions, 27 million people who don't have access to health care. And so it is about not just the access, but also the affordability.
So let's switch to talking about seniors for a little bit. To start with the timely issue, the Trump administration put out a Medicare Advantage payment rate proposal a few months ago at this point that insurers say is way too low. What do you think about that as the administration looks to finalize that rate notice?
Well, Medicare itself is one of the areas you asked earlier, what am I working on? One of the areas that I'm particularly interested in is both traditional Medicare and Medicare Advantage, and how we're shifting people over to Medicare Advantage when we haven't really made traditional Medicare simple to use. The fact that people have to buy a Medigap product to just be able to supplement, the fact that they have to jump through so many hoops is problematic. And so for us, my office, one of the things we're looking at is a fee-for-service part of Medicare, that there's an out-of-pocket, for out-of-pocket, that there's a cost cap. So we're working on a cost cap. We're working on looking at Medicare Advantage as well. I know I have a family member who has been targeted time and time again with incentives and gift cards and things like that. And this person is not healthy, should not be a Medicare Advantage recipient. And so even making sure that we look at it, this is for me, it's Medicare and traditional, as well as looking at reforming Medicare Advantage. It's workforce, as the former Secretary of Labor, so we are looking at workforce shortages. For me, it's also continuing our work on telehealth, also on health disparities. Those are the things that I've been focused on. Those are the things I'll continue to be focused on. But if you hear nothing else today, I am so excited about this working group and doing something bold, because 16 years ago was the ACA. And as President Obama said, that was a good start. But right now, where we are, where wages have not kept up with healthcare costs, we have to tackle affordability. And so that's going to be a primary focus for me too.
Let's zoom in on prescription drug costs now. Last time, obviously, that Dems had a trifecta, you passed the Inflation Reduction Act, allowed Medicare to negotiate some drug prices. If and when Democrats are in power again, should that law be expanded, or are there other things that should be done about prescription drug prices? What are your thoughts?
Most definitely. You know, I will never forget going to a senior center and talking to seniors about what we were doing as part of the Inflation Reduction Act and how it would affect their healthcare costs. And even in, many people don't know, Delaware is only 3 counties, but we vote blue, purple, and red. I was in the red part of my state at one point. A guy with a MAGA hat stood up, and I was like, I don't know where we're going with this, but he stood up and he said, prescription drug prices are a problem for me. I'm glad you're working on this. I'm glad you're fighting for it. We can't go backwards. And, you know, while Trump RX made some movements, when I talk to my constituents, while people are concerned about fertility drugs and weight loss drugs, they're really concerned about diabetes. They're really concerned about cancer. The cost of these drugs are the things that are really making their lives unbearable. And so for us, I believe it's going to be important to go back to the things that we started to make movement on, because people were starting to feel the impact of that. And so do I think we're going to go back to the Inflation Reduction Act? I think we go back to that, but we expand it. And that's, again, why this working group is so vital at this moment.
Senator, with the last 30 seconds we have left, next year is probably a primary getting underway. What role is Medicare for All going to play?
Yeah, well, I mean, again, that's why I love this working group, because it spans the ideological, generational, and geographical boundaries. To me, I mentioned Medicare. I care about dental, vision, and hearing, and I think there are great elements in that. I said elephant. That must be the elephant in the room. But there are great elements of Medicare for All, and things that we'll probably talk about in our working group. But to me, I think what I said earlier is that sometimes people get hooked up on a name, and they forget why we're doing what we're doing and what ultimately we're trying to achieve, which is to make sure that our country has access to health care, that it's easy to navigate and simplified, and that we cut red tape, and that the incentives are aligned in a way that doesn't just make some people rich, but allows many of our citizens to not be poor, just trying to have healthy outcomes. So I don't have a crystal ball. I don't know. I'm not up. Thank God. I've got 5 more years. But I do know that's the great thing about going from the House to the Senate. I can really dig deep on these issues over the next 5 years. And again, we just got to keep our eyes on the prize about what this is about. And that's making Americans healthy and not breaking the bank or going into medical debt just to be healthy.
Senator, that's a good note to end on. Yes, unfortunately, we are out of time. Thank you all so much for joining us today for another conversation that hopefully made us smarter, faster. For more info or to sign up for our newsletters, you can visit axios.com/newsletters. And to keep the conversation going, rewatch sessions on the Axios Live YouTube channel. Senator, thank you again, and thank you all.
Thank you. Give it this way.